Professor Tricia Butler here. Today we are going to discuss the progression of heart disease, a completely preventable disease, but we're going to talk about how it progresses in humans, all right? So let's start with a couple different terms, okay? Let's start with what is called atherosclerosis. Okay? And I'm a strong believer if you understand nomenclature, you could potentially solve anything that comes your way. Okay? So let's break this down just a little bit. Okay? Term athero means paste-like. Okay? Sclerosis means the hardening of. So what is the thing that causes atherosclerosis? Well, that's the buildup of plaque, right? Buildup of those LDLs, an increase in cholesterol, right? We want our HDLs, the high, healthy HDLs, to be high, and the LDLs, lousy, low, we want the LDLs to be low, right? But when we think about heart disease, it all starts with atherosclerosis, that building of plaque. How does that happen? Primarily, it comes from diet, right? Atherosclerosis is caused by diet. Things that also make a risk factors: hypertension, diabetes type 2, and smoking. Ladies and gentlemen, I will tell you, there is nothing that diabetes type 2 and smoking doesn't make worse. Okay? Obesity, that sedentary lifestyle, but it's a buildup, so it's diet related. So it starts with atherosclerosis. Now, there is something also called arteriosclerosis. Okay? So arteriosclerosis. So you can see the sclerosis is the same, so it's still about the hardening, but arterio, this means artery. So athero is diet related, while our arteriosclerosis is age related. As we get older, there's a thickening of hardening of those vessels just due to age. Okay? So the one that we're primarily going to be focusing on is going to be atherosclerosis, but it is important to understand that there is some natural hardening just as we age. Okay? So as atherosclerosis progresses, right? So start having the build up. We're specifically talking about heart disease, but this can happen anywhere potentially in the body, right? When it comes to atherosclerosis, we can talk about that it potentially affecting the heart, which is what we're going to talk about here. But it can also affect other parts of the bodies. It can affect the carotid. What does the carotid artery do? Carotid artery gives that oxygenated blood to your brain. Kind of important, right? So it can affect the carotid arteries. It can affect peripheral arteries. So a patient can have peripheral artery disease. The nice thing, or not nice thing, about the plaque that builds up is it is not specific to where it will build up. It will build up potentially anywhere in the body. Okay, but the ones that we're concerned about, we're specifically talking about here, is heart disease. Okay, so when we are thinking about heart disease, there are things that predict whether a patient's going to have heart disease, and then there are markers of heart disease, two different things, right? So when we are talking about predictors, we're going to look to see, okay, what are the things that will predict if a patient potentially will end up with heart disease, right? So we're going to look at their total cholesterol, right? How high is that? We're going to look at those LDLs. We want them low, not high. The higher they are, the scarier it gets. We're going to look at HDLs, the healthy ones, okay? And then we're going to look at triglycerides. Now, at this point, your patient does not have potentially heart disease, but if they don't change their evil ways, there's a possibility that they will end up progressing to heart disease. All right, so now at this point, okay, so you've got your patient that maybe has not had the best diet, maybe sedentary lifestyle, smoker, maybe type 2 diabetic. All right, so now they come in, and now your patient shows up. All right, so patient comes into the ER, right? And they go, I think something's going on with me, right? Right? say, I think something might potentially be happening. Okay, fair enough. Okay, so they're going to come in and they're going to complain of normally something called angina. Some people call it angina. Okay, they're going to come in with angina. Another word for angina, chest pain, right? And thing is depending on who they are and what comorbidities they have is going to be dependent on how they present. For instance, when we typically think of chest pain, we think of that pain right here in the middle of the chest, kind of that tightening, like an elephant sitting on your chest, right? That is what's known as typical chest pain or typical angina, okay? We also have what's called atypical. So atypical is going to be where you have the jaw pain, maybe the neck pain, pain that radiates down the arm, might even feel like GERD, right? That gastric pain, something along those lines. Sometimes patients don't have any pain at all. That is atypical chest pain, right? And when you're thinking of your patient population, it's actually ironic because a majority of the patients that you're probably going to see in acute hospital setting are going to be atypical, right? Because the people that are going to present with those atypical chest pains, right? The jaw, neck, arm pain, epigastric pain, those are normally going to be women, patients who have diabetes, and or patients that are elderly. If you think of those three buckets of patient populations, how many patients that you see in an acute hospital setting fall in one of those three buckets? They're either female, have type 2 diabetes, and or are elderly. That's a majority of the patients that we see, right? So a lot of them will present with what we call atypical angina, okay? The patients that are going to present with the typical are normally going to be your middle-aged men who don't have diabetes, right? As I like to call kind of the unicorns, not the patients that you see that often. So although the name says atypical chest pain, that will most likely be the symptoms that you're going to see most often. Okay, so a patient comes in and they're complaining whether it be atypical or typical chest pain, okay? So we've got either what's called stable or unstable angina. So when it comes to stable is a little bit more predictable. A lot of times stable angina, it's a fixed coronary lesion, okay? So when I say the word coronary, let's go back to our nomenclature. Coronary equals the word heart. So anytime you hear the word coronary, that actually means heart, okay? Because, again, what we're talking about is heart disease or coronary disease, okay? So in those stable ones, fixed coronary lesion, so there's some type of coronary lesion in their arteries that is causing that patient some type of discomfort, right? With stable angina, it goes away with rest, normally lasts less than 20 minutes, and a lot of times these patients will be on a specific medication called nitro, okay? And if you go back and watch the blood pressure Amazon River video, you will know that nitro is a vasodilator, and vasodilators decrease blood pressure, okay? Now, how that differentiates from unstable. So a patient that presents with unstable angina, it does not go away with rest. A lot of times the nitro isn't necessarily, may or may not do anything, right? So at this point now we're a little bit more concerned. When it gets to the unstable angina, patient is now on the progression of what's called acute coronary syndrome, okay? So again, we're talking about the heart itself, okay? Let's take a step back to the heart. What is the job of the heart muscle in and of itself? It's a pump, right? What does it pump? It pumps blood throughout your body for gas exchange, okay? So we'll start with that. But it's also a muscle. Every tissue in your entire body needs arteries to give it blood and oxygen supply, and then veins to take carbon dioxide back to be expelled from the body, okay? So when we're talking about the coronary arteries, those are the arteries that are in the heart that are feeding that oxygenated blood to the muscles so that it can pump blood to the rest of your entire body. Kind of important, right? So now you can start seeing why coronary artery disease or heart disease is such a big deal. okay? So as these patients come in, so they're going to come in and they're going to, hey, I have chest pain. Here's what's going to happen. We're going to start running all kinds of diagnostics. They have chest pain. Well, we got to figure out, do they just have a predictor of it, or do they actually have a marker of it? Patient comes in, complains of chest pain. Okay, so the first thing we got to do is we got to do tons of assessments. I think a lot of times as healthcare professionals that we tend to think, or the general public thinks, that when you come in, we know all the answers. No, what we do is we do tons of assessments, tons of diagnostics to figure out what you have. And a lot of times we figure out what you don't have before we figure out what you do have. Okay, so a patient's going to come in and they're going to complain of chest pain. All right, we're going to do all kinds of assessments, right? We're going to hopefully listen to both their heart and their lungs. Ladies and gentlemen, I know that we talk about that the cardiovascular system and the respiratory system are separate, but the only way that there's gas exchange in the cardiovascular system is because of the respiratory system. So when you are evaluating them, evaluate them together. Okay, so we're going to do an assessment. We're going to ask questions to the patient, right? Then we're going to run all kinds of diagnostics. Okay, then we're going to get to what are our markers of heart disease. Okay, so we're going to grab some labs. Okay, so we're going to grab labs. Okay, we're going to look at specifically the ones for heart disease. Okay, and we normally... So we're going to pull 3 and then an extra lab. And possibly some more, but these are the ones that I really want you to focus on for our purposes. So we're going to, these are the 3 plus an extra one, and I'll tell you the extra one. Okay? When it comes to myoglobin, it's one of the first markers to potentially go up after an injury. The thing about myoglobin is it's not specific to the heart. So if a patient were to have a fall or some type of other injury, myoglobin may be increased. That is not indicative of potentially heart disease or progression all the way to an MI or myocardial infarction. Okay? Then we're going to look at CKNB. Okay? Creatinine kinase myocardial bands. Okay? So let's talk about what myocardial means. So you see the word myo. What does the prefix myo mean? It means muscle. Cardial means heart. So myocardial means the heart muscle. So in this case, CKNB is actually looking at bands in the heart to determine if there's been some type of injury. This is specific to the heart. Troponin is one of the last markers to potentially go up after any type of injury, but troponin is our gold standard. Okay? Is our gold standard to determine if your patient has actually had an MI. Now, when you look at the troponin levels, even if they have a very small level, does not necessarily mean that they've had a heart attack. You want to look at the ranges, but that's our gold standard to determine their patient potentially have an MI. Now, you got a little plus one here, that's BNP. What we look at with BNP is, has this potentially progressed to heart failure? Because coronary artery disease, heart disease, acute coronary syndromes, those are all interchangeable. That can progress to potentially heart failure. So BNP is a cardiac test to see if a patient is in heart failure. Okay? In addition to the labs, we're going to do some diagnostics. I got to know what else is happening. Right? So, I'm going to do ECG. Okay? And in this case, we're going to get the big one. We're going to do the 12 lead. Right? Because when it comes to a patient having an MI, there are certain things that happen on a ECG. Okay, I will have another video talking about what happens with a MI. But for our purposes here, we're going to do a 12-lead ECG to see if by chance they have either potentially full occlusion, which is called an ST elevation. Okay, if you've ever heard in the hospital, if you've heard the term code STEMI, that is ST elevated myocardial infarction. This refers to something that you will see on the ECG. Okay. Other thing that we're going to look at is we're actually going to do a chest X-ray. Is there potentially something else going on? But we're running a gamut of diagnostics to figure out what is exactly happening in your patient with their chest pain. Is it something that is stable? We gave them some nitro, vasodilated, and down, or are they unstable? And we got to figure out exactly how far along they are in that heart disease process. Okay, so we're going to run our labs. We're going to do our diagnostics. All right, but in the meantime, we're going to do some interventions. Okay, so when it comes to our interventions, okay, now when it comes to our interventions, there is an old acronym, MONA. Okay, these are some of the interventions that we're going to do as we're running all of these gamut tests to help support our patients. Now, MONA is an easy way to remember it. Unfortunately, it is not in the correct order that we need to do it. Okay, ONAM is the correct. I'm going to put M here, and I'll show you why in just a second. Okay, so let's go through what each of these mean. Well, we just said that the job of the heart is that it's a pump, right? And it is pumping, hopefully, oxygenated blood. If all of a sudden we have some type of occlusion of those coronary arteries, right? All of a sudden, oh, is our heart getting all the oxygen it needs? How about the rest of our tissues? So we're going to start off with oxygen. Put some oxygen on that patient, okay? Then the next thing we're going to do is we are going to give nitro. How do we give nitro? Well, we give it multiple ways, but a lot of times in this situation, we're going to give it sublingually, under the tongue, right? And if you think about that, why would we give something sublingually, right? Well, let's talk a little bit about pharm, okay? Talking about bioavailability of a medication, right? When it comes to medications getting 100% bioavailability, fastest way is through intravenous, right? One of the slowest ways is normally taking it PO, because most medications have that first pass effect, metabolize in the liver, and the bioavailability can be anywhere from 20 to maybe 50, 60% depending on the medication, right? The nice thing about going through a mucosal membrane, like going underneath the tongue, is it's fast acting, it's absorbed quickly, and you don't have to worry about starting an IV, okay? So we're going to give nitro. And as we said, nitro is a vasodilator. So what's going to happen is, hopefully, not only are we giving oxygen to the tissues, but we're going to vasodilate those coronary arteries, hopefully giving a little bit extra space for blood to travel through to perfuse to that heart muscle, okay? Nitro, we can give 3 doses, 5 minutes apart under the tongue, okay? Then we get to A. A stands for aspirin. And what type of medication is aspirin? Aspirin is an anticoagulant, right? Why do we want to give a patient that potentially is having some type of perfusion to the heart issue? Why would we want to give them aspirin? Well, not only are we going to support them by giving extra oxygen, we're going to give them nitro to vasodilate those coronary arteries, and we're going to give them aspirin so that the blood doesn't start sticking together and coagulate. So we keep it pretty slick to keep blood flowing, okay? Then you see that I have M here at a very distant fourth, and that M is for morphine. Here's the problem if we did MONA, okay? Because the idea is, well, if we give them oxygen and we give them a little bit of nitro and it goes away, then guess what? Then potentially they're at stable angina, right? But what happens if I give my patient morphine first? Will we ever know if nitro got rid of the chest pain? Absolutely not, because morphine is going to kill any of that pain, and you will never know if it potentially helps. So morphine is a distant fourth, when we potentially know that the patient may be actively having an MI, okay? But keep in mind that all of this is we're still needing to do some diagnostics, okay? So at this point, your patient is going to go to someplace you've probably all heard of, but didn't know exactly what happened there, the cath lab. Okay, so these patients now, we got to figure out exactly the perfusion, right? We've taken an x-ray of their heart. We've taken markers for heart disease to see what's happened. We're looking at EKG, ECG to see what is happening with the rhythm. But our other diagnostic is percutaneous coronary intervention done in our cath lab. Okay. So when it comes to, also can be all percutaneous transluminal angiography, okay? But that means they're going to the cath lab, and what we're going to do is we're going to look to see how the perfusion of those coronary arteries are in your patient's heart, okay? So in that case, we are going to do, and this is a diagnostic, coronary angiography. Okay? So with coronary angiography, here's what happens, okay? So patient's going to go to the cath lab, and we're going to give them contrast dye, okay? Coronary, we've said, means heart. Angio means blood vessel, and most of you have probably figured out that ography means picture. So ultimately, we're taking the patient to the cath lab to take a picture of the blood vessels going to the heart in a nutshell, okay? So contrast dye, we're going to see what that perfusion looks like. Based upon what we see in the cath lab is going to then determine the patient's course of action, okay? If we can in the cath lab, we're going to try to fix it right there. We can do what's called a coronary angioplasty, which means surgical repair of. That's what plasty means, surgical repair of. So potentially going in and trying to rotor-rooting it out, okay, of the coronary arteries. Or we can even do what's called a stent. So we're going to do some metal mesh, going to go into those coronary arteries, open them up, and permanently keep them open, okay? When your patient goes to the cath lab, we are going to normally do this through the femoral artery, right, down here in the groin. Okay, so we're going to go up through here, go look to see what's happening first, the coronary angiography. If we can, we're going to try to clean it out or potentially put a stent, okay? If by chance we go in there and it's 100% included and there's nothing that we can do and angioplasty and stent aren't an option, our last option is coronary artery bypass graft. This is done in the operating room. What that means is where that blockage is, we're more or less going to create a detour. Okay, we're going to take vein, most likely from your patient. It's called vein harvesting in the legs. Take a vein, and from the aorta, where our oxygenated blood is coming out of, we're going to go bypass where the blockage is so that the rest of the heart can get perfusion and oxygen to that portion of the muscle. Okay, there's some excellent pictures of cabbages, but as you've probably heard of a triple bypass, quadruple bypass. That's how many places that patient had blockage in their heart. Very rarely do you ever see one. Okay, and all this starts with, again, what we said, diet. Okay, now let's talk about, okay, so your patient comes back from cath lab and you happen to be taking care of them. All right, so I just told you that we go through the femoral artery to do anything in the cath lab, to do this procedure. Well, what are your concerns with a patient post-cath lab? Okay, femoral artery, is that a very big artery? Absolutely. What is the job of that artery? The job of that artery is to supply blood to the entire rest of the leg. Okay, if you've ever taken out an IV, which I hope all of you had, how long do you have to keep pressure on it? Maybe minute, two. A lot of times you just put a pressure dressing and you're good to go. Because as we know, the venous side where we put IVs in are low pressure. But now we're talking about arteries. Arteries are high pressure. And now you talk about the femoral artery. That's a very large artery, right? So in this case, on the femoral artery, you got to keep pressure on it. Sometimes it's upwards of an hour, right? Our concern, and it's a balancing act. Everything in healthcare is a balance. Not too much, not too little. Like Goldilocks, just right, okay? But in that case, we have to put enough pressure so that your patient doesn't bleed out, right? Because obviously we don't want that to happen, but not too much pressure that we occlude the blood vessels so that the leg isn't getting any perfusion, Okay, so that balancing act. Now, there's all kinds of contraptions that we have in healthcare that help with that. No, you are not sitting there holding your hand on your patient's groin for an hour. Yes, lucky you. But there are contraptions that help with that we can control how much pressure that we have on that percutaneous site so that the patient, again, has perfusion in their leg while not bleeding out. And we're also looking that they don't have a hematoma. But based upon that location, those patients need to lay flat, sometimes up to 6 to 8 hours. If you're the nurse caring for that patient afterwards, you may be the first person that tells that patient you got to lay flat for 6 to 8 hours. Because keep in mind, they came in with chest pain. We came at them like a pit crew, ran all those diagnostics labs. We did our ONAM. We took them to the cath lab. And then you're the first person who gets to tell them that they get to lay flat for 6 to 8 hours. Okay. But as you're thinking about this, and I'm just going to draw you a quick little picture of what a CABG looks like. Okay. So a patient comes in, but all of this started with one thing only, right? It started with looking at atherosclerosis and what causes it. So if we can prevent that from the beginning, we can virtually prevent anything that happens in this heart disease cascade, okay? Last thing I'm going to show you is I do want to show you quickly. I described it, but I think it would be better if you saw it visually. So if we have the heart muscle here, this is a very rudimentary drawing, okay? And then you have the aorta coming off here. Okay? So we go to the cath lab and we're going to give this patient contrast dye as we're taking multiple x-rays to see the perfusion of the heart. If you go to YouTube, go online and look for an example of a coronary angiography, you can see exactly what it is. Textbook has pictures as well. But if by chance we see that maybe right here and going down, there's not a whole lot of perfusion. So there's kind of an occlusion here, maybe an occlusion here. So there's not a whole lot of perfusion past that, right? And we're like, oh dear, this is not good. Okay, so what we're going to do is coronary artery bypass graft. Again, we're going to take those veins from the leg, superficial veins, and no, you do not necessarily need them. Or we do have veins that we keep on, that we keep frozen, donors, that in case the patient is not a candidate for vein harvesting. But if we can keep it in your own body, that's ideal. Okay, so what's going to happen is we're going to take one of those veins and we're going to attach it right here off of the aorta because it has oxygenated blood. And we're going to take that little bad boy and we're going to attach it just like this so that the rest of this right here ends up getting blood perfusion. Same thing. I'm going to do another one right here. So at this point, so again, hopefully our heart will get. That's only 2, okay? That is a double CABG. That is not a triple or a quadruple. That's a double CABG. Most of the time, guys, you will hear triple, quadruple, or sometimes even more than that. But that is exactly what a CABG looks like. I will be making another video to talk a little bit more about MI, what that looks like on an ECG. But as you know, one of the things with the MI is the patient may end up either in cath lab or progress all the way to the operating room and the CABG. I hope that that overview of heart disease shows you the progression of how it starts with atherosclerosis and can lead all the way to MI and even possible death. And at any point in that time, if we as healthcare professionals can nip it in the bud to stop it to get to this, that is our responsibility and being proactive in helping our patients as much as we possibly can. Thank you for your time. I hope that helped with your understanding of heart disease. Have a beautiful day.